بسم الله الرحمن الرحيم. Today our lecture will be in traumatic glaucoma. So when you hear about traumatic glaucoma, what you are thinking about? Can you dim the light, please? So when we talk about traumatic glaucoma, what come in your mind? Anger recession. What else? Hyphema. Zonule dialysis. So, but always what comes to your mind when we talk about anger recession, traumatic glaucoma? Usually you think only about anger recession. Maybe when we finish this lecture, you will see a lot of things occur in traumatic, after trauma, not only anger recession. So traumatic glaucoma, there is actually different underlying mechanisms that lead to common pathway for elevation of intraocular pressure and increase the risk of optic neuropathy. Definitely when we call the term glaucoma, you should have optic disc damage accompanied with visual field change. You may have glaucoma after trauma without disc damage and visual field change. We call it just a transient rise of intraocular pressure, but it is not definitely go into this item of glaucoma. So transient rise of IOP after injury is not truly glaucoma unless it produces damage and visual field change, as we mentioned. So the traumatic glaucoma can be surgical or non-surgical trauma. You can see can be blunt trauma, can be penetrating. But glaucoma after blunt trauma usually occur in 8%. This is according to published study. There is very few published study about penetrating trauma in relation to blunt trauma. Blunt trauma glaucoma 8%. And the average in penetrating trauma, glaucoma occur in about 4 to 5%. There is classification also of non-surgical traumatic glaucoma, blunt injury, penetrating injury, early onset and delayed onset. The early onset iritis, hyphema, lens dislocation, anger recession, ghost cell. In delayed onset after blunt trauma, it can be anger recession, ghost cell. In penetrating trauma, we should rule out epithelial and stromal downgrowth and siderosis. So again, early and delayed onset, you can see this is an example of delayed onset in which the longitudinal muscle is attached while the circular muscle is detached in case of anger recession glaucoma. You can see again blunt ocular injury can occur after airbag and they can be overlooked by the circumstances of more severe injury. Usually this is actually what happened. In case of severe injury, usually they mistake the trauma occurred to the eye, blunt trauma to the eye, maybe has a chest injury, brain injury, and usually it is mistaken by patient and the team. And we know that anger recession glaucoma can occur very late, maybe after 40 years of history of trauma. Don't forget the 7 ring. This is very important when you have blunt trauma. The pupil tear, iridodialysis, anger recession, cyclodialysis, trabecular meshwork tear, zonule dehiscence, and retinal dialysis. This is one of our patients with blunt trauma. You can see the effect of this blunt trauma to the pupil. When there is paralysis of the sphincter pupillae muscle, the pupil will be dilated. So not always dilated pupil means some patient, I just have a call in the morning from one of my colleagues. He has a baby born with dilated pupil, 5 days with congenital glaucoma. He asked me, we want to do visual evoke potential to evaluate the vision before he operate for congenital glaucoma. You agree for that? A baby born 5 days with dilated pupil, congenital glaucoma. He want to evaluate the patient can see or not. In a baby 5 days. طبعا not all dilated pupil means blind eye. The dilated pupil may be partial aniridia, may be trauma, may be third nerve palsy, may be medications. So not all dilated pupil means a blind eye. Anyway, this is not our, this is dilated pupil. You can see commercial retina here. You can see zonule dialysis. This is all effects of blunt trauma to the eye. So this is very important when you have trauma, which is traumatic iritis. Usually initial IOP is often low. So you may have patient with cells in anterior chamber while there is low intraocular pressure. What is the explanation of that? So this is most likely ciliary body shut down. But usually after some time, the IOP start to raise again. And this is due to clogging of trabecular meshwork with the inflammatory debris or sometimes blood. It has been opposed that swelling of trabecular meshwork itself may also contribute to outflow obstruction. What about the treatment of traumatic iritis? Usually topical steroid is enough. You can give beta blocker, carbonic anhydrase inhibitors, plus minus cycloplegic. Yani if the patient not in severe pain, it is not necessary to put the patient on, like example, atropine. You can give mild cycloplegic. But if there is no pain, yani you can go only with topical steroid. There is some drugs should be avoided in traumatic iritis, which is pilocarpine and prostaglandins. What about hyphema? Traumatic hyphema, usual acute rise of IOP due to mechanical obstruction of trabecular meshwork by the blood or fibrin. A chronic rise due to permanent damage of the trabecular meshwork. That's why when you have a case of long-standing hyphema and you go to remove this blood from anterior chamber, it's important to take the history. How many days this blood in anterior chamber? Because of long-standing hyphema can damage the trabecular meshwork. So the drainage is not enough. The patient may need glaucoma surgery. There is controversy regarding actually, you know, aminocaproic acid ده antifibrinolytic, يعني بيمنع الكلوتينج انها to dissolve. طبعا because of severe bad side effects of aminocaproic acid اللي هو اسمه amiclar, nobody usually is use this. You can see all complication here. Down, diarrhea, dizziness, fatigue, tenderness, general body discomfort, all this will allow us not to use this type of medication to stop dissolving the clots of hyphema. So patients with history of hyphema who go into develop glaucoma are usually approach an angle recession patient even in absence of recession or examination. What is this? When you have a patient of hyphema, you should look. طبعا it is not advised to do gonioscopy when a patient came to you with hyphema. Because if you do gonioscopy, you will increase the tendency of rebleeding again. But when the patient, the blood disappears, you should do gonioscopy to rule out angle recession. So what is indication of the drainage of hyphema or blood? 8 ball. Okay. Cycling 24 hour. ايه تاني؟ البريشر. corneal staining. 8 ball. البريشر بقى كام الاي بي؟ more than 35, 5 days to 7, we 50, 2 to 3 days. Very good. But as I mentioned, when you go to drain hyphema, especially with long standing, it is better to do trabeculectomy at the same time, and it will help to drain the blood faster. What about lens dislocation? The problem of lens dislocation after blunt injury is not only visual disturbance, but the problem in also corneal decompensation. The lens, when it touches the endothelium, it makes problem, and it is important indication, urgent indication to do lensectomy. So it is not a problem also of high IOP, but also lens corneal decompensation, and the lensectomy will be an emergency surgery in this situation. What about posterior dislocation? If the lens displacement to posterior, the only treatment is vitrectomy. Sometimes you have vitreous hemorrhage. Long-standing vitreous hemorrhage, you know, the RBCs became rigid and it became attenuated and it can escape. Somebody tell me in aphakic patient how to escape. You can understand this in pseudophakic. But in aphakic, how can escape? Anyone can mention? In phakic patient, how ghost cell can occur? Excellent. Because we mentioned before the 7 ring. So the patient may have also the neural dialysis or dehiscence or weakness in some area in which these RBCs can escape and go and block the trabecular meshwork. So vitrectomy with AC washout, with or without, again, trabeculectomy according to the duration of the disease. So if we come to angle recession glaucoma, this is big topic now, and we can go for background, how they mention this and when it occurred. It is actually in 1892 by Trish and Collins, based on the first report of post-contusional angle deformity and growth examination of inoculated eye. Then Domprin observed in 1944 association of ocular trauma and chronic unilateral glaucoma. Then Zimmerman in 1962 and many authors have confirmed the relationship of glaucoma with traumatic angle abnormality. Angle recession glaucoma is classified as a type of traumatic secondary open angle glaucoma. And this condition may be underdiagnosed because of history of eye injury. Most likely it is forgotten. Nobody will remember. So angle recession with or without glaucoma characterized by variable degree of cleavage between, as I mentioned, circular and longitudinal muscle fibers in cellular body. What about the pathophysiology? There is 5 stages actually. The first stage, the blunt force, as you can see here in the picture, when there is blunt trauma to the surface of the eye, delivered to the globe initiate at an anterior to posterior axial compression with equatorial expansion. And the sudden indentation of cornea may be a key factor in angle trauma, creating a hydrodynamic effect by which the aqueous is rapidly forced laterally, deepening the peripheral anterior chamber and increase the diameter of corneoscleral limbal ring. As you can see here, this is what happened actually. The second stage, there is transient anatomic deformity result in shearing forces applied to the angle structure, causing disruption at the weakest point. If the force applied exceed the elasticity of the tissue. The third pathology here in angle recession, the cellular body is torn, as we mentioned, in a manner such that the longitudinal muscle remain attached. And actually the longitudinal muscle is not changed, but the circular torn, and it be away from this, and this gives the widening of the angle. And in this situation, actually there is also rupture of blood vessel in this area. And that's why most of cases of hyphema they have some sort of anger recession. During this process, sharing of the anastomotic branches of anterior ciliary arteries can occur, result in hyphema. The anterior chamber typically become abnormal deep in the meridian of recessed angle due to posterior deviation of the relaxed iris lens diaphragm. Subsequently, a fissure representing separation of longitudinal and circular muscle fiber may be visible by gonioscopy or by histologic examination. In some cases, anger recession progress to glaucoma. طبعا not all cases of anger recession get glaucoma. We'll discuss later on what is the cases can progress to glaucoma. The trabecular dysfunction, which may lead to early or delayed loss of outflow facility and the elevation of IOP. The mechanism is not well understood, but evidence suggests an increased incidence of primary open-angle glaucoma in the other eye. Anyone know how the glaucoma occurs in the other eye in anger recession? Yeah, he has genetically predisposed to glaucoma. So when there is initiating factor in this eye, which excites the glaucoma early in one eye, he has already genetic predisposition to glaucoma, so he has 50% risk to develop glaucoma in the other eye, which is primary open-angle glaucoma. A limited portion of trabecular meshwork in eyes with anger recession is initially redundant, dysfunctional by the injury or the healing process. With time, outflow capacity of the remaining meshwork is gradually reduced because of pre-existing innate factor and ultimate result in elevation of IOP. طبعا definitely here there will be some sort of fibrosis in trabecular meshwork, dysfunction of trabecular meshwork, but on histopathology they found that there is what we call it endothelialization of the angle. And when you are asked about the mechanism of glaucoma in anger recession, early due to inflammatory things, but late on due to endothelialization. So this is the difference between rising pressure in anger recession early and late. The chronic elevation of IOP will lead to optic neuropathy, optic disc cupping, and visual field changes. So but what is about the frequency of anger recession in the United States? The reported frequency, the complication of blunt trauma, 20 to 94%. Several reports have described incidence of anger recession in more than 75 of blunt injuries eyes, and anger recession after traumatic hyphema occur up to 100% of cases of eyes with particular anger recession. The risk factor of progression to glaucoma after ocular contusion include chronic elevation of IOP, poor initial visual acuity, advanced age, lens injury, and hyphema. The glaucoma after anger recession of less than 180 degree is unusual. So when you have anger recession less than 180 degree, it is not common to have anger recession glaucoma, but definitely a recession more 180 is a risk factor to develop glaucoma. And usually it's about up to 10%, 5 to 10%. So eyes with anger recession greater than 24 appear to be high risk of chronic glaucoma. What about morbidity and mortality? The ocular injury is relatively common, so morbidity in patients admitted with major, as I mentioned before, usually they have another major injuries. Definitely it can occur after many years of trauma. And the problem that most of patients, they forget the history of trauma. What about race? Any difference in race? What do you think? Any difference? No non-racial preference exists because of the possible relationship of open-angle glaucoma with angle recession. It can be theorized that American, African may be increase the risk of glaucoma after congenital eye trauma. A comparison of rates of progression to angle recession glaucoma among different races have not been reported till now. What about sex? Huh? This males with females. At home. Female is more prone to trauma at home, is it? Well, now no difference? No difference. We'll see. طبعا no sex detector for angle recession glaucoma has been reported. Strong predominance of eye trauma exists in men when a male to female ratio 4:1. Therefore, it may be assumed that the angle recession and the angle recession glaucoma occur most frequently in men. Among children, eye injury occur more frequently in boys than girls. Compared with men, women appear to be at great risk. هذا الكلام بقى at home. So how you defend yourself? Take care of this. Very important. What about age? Advanced age has been reported an independent predictor factor risk for developing glaucoma after ocular contusion. Definitely طبعا اليونج healing process is better than old age, and the old age is risk factor actually for open angle glaucoma. Because of the potential for delayed or late onset after blunt trauma, angle recession is most likely diagnosed in mid or late adulthood. It may misidentified as primary open angle glaucoma because angle abnormality may be subtle on examination. This is very important because you may examine patient, diagnose him as open angle glaucoma, because by time the angle changes will be different actually. And you may find the patient of open angle glaucoma, one eye is open angle and the other eye there is angle deformity. What about the history we mentioned before? That the patient may forget the details of injury. This is very important. Unilateral cataract in a young child. When you have unilateral cataract in young child or middle-aged adult, you should raise suspicion of history of glaucoma. We got a lot of patients operated by cataract with high IOP. How? A patient came to unilateral cataract, then the surgeon did cataract surgery, and when you do cataract surgery, we found that the disc is damaged. And because when you have unilateral cataract, usually you should look for gonioscopy, and the intraocular pressure may be high, and you didn't observe that, and the post-op you found that the patient has no good visual potential, disc damage, and the pressure start to raise again. In case of suspected traumatic angle recession, careful history should be taken. This may elicit otherwise forgotten information. In elderly patient, rule out history of falls. This is very important. Many patients, they fall down and they forget this, that they fall down and they have, this is in the history. Unilateral elevation hallmark finding of angle recession, but it may not be noted in early stages of the disorder. Angle recession is always diagnosed by means of gonioscopy. Without gonioscopy, you cannot diagnose angle recession. The clinical appearance of affected angle varies with the depth of tear in the cellular body and with the amount of time passed after injury. A wide cellular body band visible on gonioscopy, this is the hallmark of angle recession. You can see here in this picture. But somebody will tell me maybe this is normal, wide cellular body. Yes, but you should compare other eye. So if you make gonioscopy for one eye and you look to the other eye, or compare part quarter to quarter. You compare quarter to quarter. If it is 360 degrees, you compare one eye to the other eye. So what is the differential diagnosis of angle recession? Angle recession should be differentiated from psychodialysis. ايه الفرق بينها وبين السايكودياليسيس؟ لا لا لا. IOP. IOP also, yeah. This is separation completely. ولكن ال IOP is extremely low. There is another anterior segment abnormality. طبعا لما يكون عندك angle recession لازم تبص على الحاجات التانية اللي الايريدوداليس سايكولوداليسيس، ايروسكايسيس، انتيوساينيكيا، اسفنكتر تيرز، ميدريزز، ايروس اتروفي، ترانسلوميشن ديفكتس، ايرايتس، جينيول بريكس، فيكودينيسيس، سبلاكسيت لينس اند كاتاراكت. And also you should look for posterior segment, not only anterior segment. You should look for vitreous opacities, cerebrochoroidal tear scars, macular holes, retinal tears, detachment and optic atrophy. So about the causes of angle recession, as we mentioned before, any cause of non-penetrating ocular trauma can result in angle recession. What about penetrating trauma? It can cause angle recession? This is question to you. Yes. Yes. Even the penetrating trauma, it has some sort of, yes, blunt trauma. And they may be associated with blunt trauma also. So even we will discuss later on that even penetrating trauma, they have some sort of angle recession. احنا قلنا the circumstances of injury can be variable, often involving trauma of high velocity, blunt object, or like stones, balls, الكلام اللي احنا قلناه قبل كده. This is the causes, most common cause of blunt trauma اللي هي السبورت injury, motor vehicle accident, الاسالت, الفولز, military injuries or accident. This is the most common causes of blunt trauma. And this is the hallmark of diagnosis of, you cannot diagnose without, as we mentioned, gonioscopy. And طبعا this is interesting to know about this lens, which is Zeiss lens, which you can make pressure. طبعا here in angle recession, no need to make pressure gonioscopy because the angle is already wide. What about treatment of angle recession? طبعا there is mild cases actually, in which you can get angle recession with borderline pressure, not high, and disc is not damaged, and he can be controlled with one medication. But usually severe cases you should go for surgical interventions. So now we will come to second item, which is penetrating trauma or injuries. Maybe there is video here. I don't know it will work or not. It is not working, no problem. So penetrating injury, penetrating trauma tend not to follow any predictable pattern. Actually, you don't know what will happen after. يعني when you have rupture globe or open globe injury, not all open globe injury or rupture globe is the same. You may have zone 1 injury, zone 2 corneus clear, you may have zone 3, you may have intraocular foreign body, you may have lost tissue, you may have iris prolapse. You don't know actually what will happen, especially after you repair open globe. Many of the same mechanism encountered with blunt trauma can also be at play in case of glaucoma after penetrating injury, phenomena such as hyphema, angle recession, ghost cell glaucoma. يبقى اللي بيحصل مع البلانت تروما can occur also with penetrating trauma. Long-term use of steroid. This is one of the important things as a cause also of glaucoma after penetrating ocular. Sometimes you give steroid more than 6 weeks. And sometimes you increase the frequency of steroid to suppress the inflammation so you can get steroid responder and high IOP. Any penetrating injury can initiate inflammation that eventually lead to uveitic glaucoma. Inflammation must be carefully controlled. Cycloplegic usually recommended in acute phase. Any glaucoma patient with history of trauma must be examined for peripheral anterior synechia. Why? طبعا احنا لما نشوف الستاديز بعد كده the most common cause of glaucoma after penetrating injury is secondary angle closure glaucoma. طبعا انت بتشوف الاي سي collapsed rupture globe, and when you repair rupture globe sometimes the AC is not formed well, there is inflammatory exudate, then you can see the patient post-op have increased high intraocular high IOP. So they found that majority of cases they develop peripheral anterior. عشان كده when you repair rupture globe, it is not only to repair the injury but also to make visco, gonio. You go to the angle and inject healon in the angle when you repair rupture globe. Intention. This will release the angle from any synechia or inflammation or anything in the angle. This may help to also if there is adhesion, you remove it. Yeah. So what about epithelial downgrowth, which can occur? Most likely this occur after surgery. And it is a rare phenomenon with devastating consequences. Surgery is the leading cause. Clinical presentation of epithelial downgrowth can occur from 4 days to 38 years after the initiating surgery or events. There is retrocorneal membrane and patent fistula can occur. Medical management relatively ineffective. Usually they need surgical intervention, which is epithelial downgrowth. Surgical removal or cryo can occur, can help to remove this epithelial. Axial fibrous downgrowth or stromal it tends to be less destructive than epithelium, and the medical treatment can be successfully treat this condition. What about intraocular foreign body? The retained intraocular foreign body cause damage to trabecular meshwork and influence the development of glaucoma, secondary open angle glaucoma due to iron deposition in the trabecular meshwork. They call it sidrosis. So excessive iron either from the return foreign body or from hemosidrosis can lead to severe damage in the eye. 40% of open globe injury retain some amount of intraocular foreign bodies, and examination finding including heterochromia. This is a manifestation of sidrosis. Heterochromia, dilated and poorly reactive pupil, rust-like deposits, optic disc edema, glaucoma, and pigmentary retinopathy. So this is all the manifestation of sidrosis in the eye. Any eye with retained metallic foreign body must be followed closely for glaucoma. This is one of the patient. This is pen actually, which hit the lid's eye and go to up to the brain. So a short time before we finish, we'll talk about the penetrating trauma after open globe injury. Actually, we have two studies in that. We collect a patient about 10 years or 11 years. كان عدد المرضى أعتقد 775 eyes. They have rupture globe, open globe injury. Then we look for who developed glaucoma in this patient. How many patients develop glaucoma? We found that 41 eyes, يعني حوالي 5% they develop glaucoma and others they didn't develop glaucoma. So here we look for the incidence and the risk factor of glaucoma after open globe injury. This is the first study. We investigate the incidence and the risk factor after open globe injury, the glaucoma occur. It was a retrospective study actually. So the result, as we mentioned, that the risk factor was about 5%. And you can see this is the univariate analysis. We look for age, for gender, for vision, the mechanism of injury, the type of the trauma, the extent of trauma actually, we look for the also lens injury, whether it is there intraocular foreign body, vitreous hemorrhage, vitreous prolapse. We want to look for what is the risk factor of developing glaucoma in this number of eyes after the repair of rupture globe. So univariate analysis revealed that zone 2, we know zone 1 corneal injury, zone 2 corneoscleral, zone 3 posterior involvement. They found that zone 2 perforating ocular injury, lens injury, vitreous hemorrhage, presence of foreign body is a risk factor to develop glaucoma. Actually, the age more than 18 was critical. It was trend actually, but not statistical significant. But following the logistic regression, perforating ocular injury, lens injury, and vitreous hemorrhage were significant risk factor to develop glaucoma. So put this in your mind when you have a patient of repaired rupture globe to follow him for increased intraocular pressure. There is actually, when you look for PubMed, only 3 studies talk about glaucoma after open globe injury. One in America, which is by Jerkin, and one in Italy by Terbela, and our study. The number of patients in Jerkin study was huge because it was multi-center study. About 3,000 multi-center study, and the incidence of glaucoma after penetrating injury was about 3%. In our study, the number of patients was 775, and also it is around comparable 5.3%. So why here in this study the incidence is 17%? Actually, when we look here, this is a risk factor: advanced age, lens injury, poor visual acuity, and here increased age, high female lens injury. In our study is the same as we mentioned before. Actually, in Terbela study, they include a patient. You remember when I started the lecture, the difference between traumatic glaucoma and the traumatic rise of IOP. They include the transient increase in IOP. In our study and Jerkin study, they only include the patient who develop really optic disc damage and visual field change. This is the difference between this study and our 2 study. They include the transient rise of, that's why the percent is 70%. So conclusion of this study, glaucoma after open globe injury is not uncommon. Zone 2, perforating injury, lens injury, presence of vitreous hemorrhage, presence of intraocular foreign body were significant risk factor. If we go back here, I forget to mention something. Here, why also incidence is less. In Jerkin study, actually, the protocol in America that they remove intraocular foreign body in the same session of removal of intraocular foreign body. But in our protocol, in our hospital, we repair the eye, close the eye, then within 1 to 2 weeks, the retina surgeon removes the foreign body. So they don't have intraocular foreign body as a risk factor for glaucoma. This is the difference between Jerkin study and our study. What about the second study? Actually, we got 41 cases from 75 patients that developed glaucoma. We want to know what is the cause of glaucoma in these cases and what we did for them. So we look for them again in another study. This is published in Journal of Glaucoma. Causes, as you see here, causes and the management of glaucoma after open globe injury. So objective of this study, as we mentioned, to study the cause and the treatment. When we look for this patient for gonioscopy, we find that 23 patients, they have open angle, 14 closed angle, and 4 patients, they have angle recession, in spite of penetrating, as we mentioned. Yeah. And when we look for the causes of glaucoma, we classified them into early, intermediate, and late. You can see the early within 1 month here, you can see, and intermediate up to 6 months, then more than 6 months. We found that the causes of glaucoma in early is the unremoved lens particle inflammation hyphema. In intermediate, synechial angle closure, ghost cell, and unremoved lens particle. Late angle recession and synechial angle closure. And you can see synechial angle closure is repeated, which shows that this is the commonest cause of glaucoma after repair of ruptured globe. And you can see here the treatment done for this patient. Here maybe it is looks better. 5 cases we did CBC, 9 lens aspiration, 9 trabeculectomy, Ahmed tube in 2 cases, AC washout 3, lens removal with vitrectomy, and total amount of the cases. And this is the success rate for them. So it is seen even in penetrating trauma that you may have angle recession. So in conclusion, traumatic glaucoma presents one of the most difficult complications of eye injury. It may appear in early post-trauma or many years after trauma. Patient education, careful surveillance, and early interventions provide post-traumatic patient with best chance for long-term vision preservation. Thank you. Usually it compromises the angle. That's why you have high IOP. But the fistula inside it is not like a leak. No leak outside. لا, in the cyst itself. But it compromises the angle. It is not a sort of leak outside and there will be hypotomy. Yes. لا, it will not connect outside. Any other questions? اتفضل. معلش تاني مش سامع. No. Good question طبعا. طبعا definitely low amount of patient you cannot get, but I don't have studies to show this exactly 50%. But if you have يعني if you collect more number, it will give real actually how many percent it will come. Definitely. Yeah. I think maybe multi-center study also will help to elicit the exact how much. Any other question? Thank you very much.
The same thing, right? Did you talk to your boss? And what did he say? Recognizing everything. Okay, it's all working. Do we have 6 minutes?
Maybe the same way that I Good afternoon, everybody. It is my pleasure and honor to introduce to you Dr. Sherhill, which is my colleague and good friend from Venezuela, who joined the glaucoma division about 5 months ago. Dr. Sherhill was born in Venezuela and did his glaucoma specialist in Spain. And he's going to give you an overview about how we should approach the treatment of glaucoma. Thank you. Welcome.
Well, good afternoon. 1.5 years ago, I was standing here as an invited professor, and now I'm joined this great family, and I feel proud of it. And I want to take the chance to say thank you to all of you for making me feel like in home. It's not easy to say that, but I really do. So I'm going to try to cover some points. These are my goals about the talk, and honestly, I don't pretend to resolve any of those doubts. I hope that you are going to take those doubts back home. If you think about it, if the next time that you face the patients, you think about it, then my goal is reached. When we talk about glaucoma, we talk about a general disease that basically kills the retinal ganglion cells, and in which the IOP is one of the risk factors. The European Glaucoma Society defines the glaucoma basically like a chronic progressive optic nerve disease. As you can see in the definition, there is no IOP mentioned. If we talk about etiology, it remains unclear. There is multiple genetics factors, comorbidities, and still the pressure is not included. What is the pressure? Pressure is involved in the pathophysiology. The deformation of the lamina cribosa related to the level of intraocular pressure, it's what it causes the damage. But not all the eyes respond in the same way to the same level of IOP. So that will really question the way we treat the patient. It's something that we should think about it. When we talk about the pressure, mainly it's the only factor that we are able to modify. That's why it's so important to us. I don't know if you know these devices. This is the triggerfish. It's basically the halter. It's a halter for intraocular pressure. It's useful. Well, so. I had the opportunity to work in Europe in the development when they were testing this device. And what we found, and I'm going to mention a little bit about it, this is that patient that I show you on the picture. And as you can see, basically the most important thing is this device doesn't measure pressure. What it measures is electricity, microvolts. It measures the change that the anterior segment of the eye suffer, supposedly related to modifications of the pressure. But what you can see is this patient has a progression in glaucoma. During our daily visit, which is this time frame, the pressure was in a normal level. But at night, while she sleeps between 3 a.m. to 9 a.m., the pressure, or whatever we were measuring, in that case, microvolts, it was very, very high. 12 after the treatment, you can see that there is a flattening of that curve. So the stabilization of the IOP, the flattening of the fluctuation, is an important risk factor in the progression of glaucoma. When we talk about the prevalence, there are many, many studies about it. The important thing that you have to keep in mind is that 50% in all the studies are undiagnosed. That is our goal, trying to reach those part of the population that is probably not diagnosed. There are many factors involved. There are some that are strong association, like the intraocular pressure. The age is age-related. Ethnicity, different races, has different progression in the glaucoma and different presentation of the glaucoma. The family history is very important. Then some moderate association, we don't have it very clear, myopia, diabetes. We know that patients that have myopia and diabetes tend to assist to see the ophthalmologist more often, and that is one of the relations sometimes they found. And some weak association like systemic hypertension or migraine or vasospasms that is not totally clear. And for the diagnosis of the glaucoma, well, our basic, as I said, is the pressure, but mainly because it's the only thing we can change. The slit lamp exploration is very important because it will give us the idea of what are the other risk factors associated. Pseudoexfoliation, pigmentary glaucoma, neovascularization, all of those will change our concept about the way we have to treat these patients. The synechias, or the widen of the angle, is going to give the last name to this glaucoma. Not only the name is important, it's also very important the last name of the glaucoma, because according to that, we're going to adjust our treatment. Nerve fiber layer and optic nerve is the key point. The problem with the investigation and research in glaucoma is that we have 3 different areas. The studies are oriented to the ciliary body, the production of the aqueous humor, trabecular meshwork, where the outflow is, and the target organ, which is the optic nerve. That is so dense, and that's why the investigation in glaucoma doesn't go as fast as we would like. Visual field is very important too, but has one inconvenience that is key. And the inconvenience is that depends on the reliability of the patient. If the patient understands the test, the patient is going to do it good. For us, it's not only one of these part of the exam. The important thing is that everything match as a puzzle. If you had a damage in the optic nerve, it should match with the visual field. You should look for an aggressive factor like the pressure or any other condition that is involved in this progression of the patients. When we talk about the histopathology of the glaucoma, there are many changes. What it seems to happen is that is an early change as the one related to the age. In some cases, the collapse of the Schlemm canal is what it produced that the aqueous humor cannot leave the eye, but it's not the only mechanism. So that's why it remains unclear. This has about 12 years. I think that when Weinreb present this, but for me, it's one of the most important things because it tells us the progression of the glaucoma. We are only able to detect the changes that the glaucoma will have when the disease has passed 2/3 of the vital cycle. So it's very important to try to detect the earliest we can, because mainly when we do that, we will have more options to it. And what are the principles of the treatment? Basically, as I said, the goal of the treatment is the pressure, because it's what we can change. But of course, we have to preserve the quality of the vision, the quality of the life, according to a reasonable price. And what is that pressure? Well, basically, most of the studies said that if we are able to decrease the pressure 30% from the basic level in which we make the diagnosis, we're going to be moving into a safe place. But one of the most important studies was the Advanced Glaucoma Intervention Study, and it found that if the pressure in all the visits remained below 18, the progression of the visual field or the damage in the optic nerve was really, really slow, or it was none. So that's why we keep in our mind that we have to keep the pressure the lowest we can, and if it's below 18, the better, but at what cost? This is what the European Glaucoma Society tells us as the whom to treat graph. If you see these lines, the line 8 is the normal decrease that everyone has related to the age. The line B is a moderate rate of progression, but in an old patient. So if we have this line, how aggressive we have to be in a patient that probably has a life expectancy of 10, 15 years, or the same situation if the life expectancy is only 5 or more years. The line C is the same progression rate, but in a younger patient. We have to act differently in both situations. Line D is a slow progression rate, but in a patient that is tolerating well that. We should not create an extra stress in the patient. If the patient is not feeling anything and we are observing that there is not changes fast in the visual function, we should consider that at the moment of initially the treatment. On the contrary, the line E is a very fast progression of the disease. That is something we have to act, and probably very aggressive, in order to slow down that progression. According to all these factors that we are going to get that target IOP. And most of those factors are related to the glaucoma damage, the life expectancy, the untreated level of IOP, the additional risk factor as pseudoexfoliation, pigmentary glaucoma, neovascularization, or the rate of progression. According to that, we have to adjust that level of IOP. And how we adjust the target. The most important is when we are evaluating a patient, having in mind that that level of pressure we consider is the target pressure can be adjusted between visits according to what we find in this patient. This is a case. This is the optic nerve in one eye. You can see the enlargement of the excavation, the matching of the visual field with that defect, clearly a glaucoma. In the other eye, between the normal limits, it matched the puzzle with the visual, with the OCT in that eye. Important defect here. If you trust the ganglion cells, you can see that there is important damage in one eye and start the damage in the other eye. We're going to talk about the solution of this case later on. So now we have the steps of the treatment. What are we going to do? Those steps will be based on age and the disease progression. But most of us will be agreed that our first step, it will be a start with medication. Well, we have all of these medication. As you can see, some of them came from the 19th century. And the last fixed combination came in this century. According to that, and taking into consideration some systemic contraindication, how is the surface of the eye, or the concomitant disease, we're going to choose our first medication. Can you start with fixed, full, or more than one medication? Yes, you can. But the important thing is you must know the response to the treatment if it's according to the drops you are using. If you start right away with full medication, you don't know if all of them are working. And that is important to know. Sometimes it seems that they are all working, and some of them are causing side effects that you don't want that side effects. According to that, you have all these first choice monotherapy. And as the European guidelines said, probably I will change this as I get used to the Saudi guidelines, as you had, all these drops should be changed according to the response to that treatment. But take into consideration that if you use more than one medication, the patients are only be compliant according to some studies in 30% of the cases. As you add more drops, the patients comply less. It's not easy. Think about it. This is a study of basic on the washing effect. What mean washing effect? Well, if I use a drop and I wait only 30 seconds of interval between that first drop and the second drop, I'm only going to have a biodisponibility of the medication in 50%. If I wait 2 minutes, the biodisponibility of the medication is going to be 83%. And if I wait 5 minutes, I will have the full biodisponibility of the medication. But how many of our patients will wait 5 minutes between drops if they have 3 drops? Will you wait 5 minutes between drops? That means 15 minutes in the morning, 15 minutes in the night. You probably have to watch TV. So it's something important to keep in mind when we prescribe the medication. The second thing related to the interval between the drops is that if you wait the 5 minutes, the maximum decrease of pressure, the maximum effect of the drop you're going to get. If it's quick, the waiting, you're going to have less reduction. So the add phenomenon of the medication is not like I give full medication and I don't give the direction of leave the interval between the drops. That plus the lacrimal point occlusion is very important when you use the medication. We did a paper on when the last prostaglandin came out, which was the bimatoprost, and we found that even with the good ones, the patients will decline in using it. At the end, most of the patients, and you can see it, I will say that my patients in Spain are quite similar to the Saudi patients in the way that, have you used the drops? Well, I ran out of the medication 1 month ago. The same answer I receive in Spain, I receive it sometimes here. So we did a study in Spain, and I'm sorry that the paper is in Spanish, but here it said that most of the patients need twice or 3 times trying to put the drops, and in about 30% of them, the drops fell in a different place than the eye, nose, cheek, and some other places. These are 2 real patients that we ask to put the drops. As you can see, she puts a lot of them. She's still saying that she has only 1 drop in, and this lady lost 1 eye because of glaucoma. She said that she put the drop, but you can see that she did not put any drop. The problem with the patients is that there are a lot of things depends on how the patients use the drops. Hardness of the containers, some of the bottles are very hard, shaking hands and arms, all patients has a lot of these problems. Installation, that usually is not appropriate. The best treatment in medication is the one you put in the eye. If you don't put it in the eye, it won't work. And the compliance will depend on different factors. This is another lady, and she's complaining that, well, she has the glaucoma, she has 1 drop, but the bottle is very hard. And she developed her own system to apply the medication. And we were wondering, and the next visit we said, well, why don't you bring your system to apply the medication? Do you know what is this? You use it here too, right? Not that very good for the heart. So she had that nook cracker, and she used to squeeze the bottle. So some patients are very creative in the way to use the medication. But the important thing is when we talk about drops, when we talk about meds, we really have to discuss that point with the patient. I think that in a lot of points it's very important that the patients understand the importance of using the drops to keep the pressure at that level. And that is probably, right now, I will say, is my main concern. I'm not able to communicate as I would like, and I will thanks publicly all the translators that helped me, but I would really will enjoy to understand how the patient said, or what the patient said about the administration of the drops. So once we pass the med status, then we go into another way of treatment, which is the SLT, or the laser treatment. SLT against the ALT has the advantage that it doesn't change the anatomy of the trabecular meshwork. And in this study, based by cats, the FDA approved the use of SLT as initial treatment. Basically because the effects compared with the medication was similar, at 25 to 30% of reduction of the IOP. The good thing is that residents do as good as the consultants. So anyone can do the SLT, and it will be a good option. And also, the important thing is that the SLT has a reduction of about 23, basically is what every medication has as an additive effect, and it works better in the pigmented trabecular meshwork. Depending on the pigmentation of the trabecular meshwork, the effect of the SLT is even larger. So when you keep going up the stairs, you have that if you start with the medication as the first step, or the SLT, the second step should be the opposite. That's in theory, right? And that's what we are talking. But what happens if that effect of IOP control is not reached? The IOP fluctuation can be a second factor, or there are some other things imply in the progression of the glaucoma. Then we will have to think about the surgeries. And what surgeries do we have? Well, our most common, the trabeculectomy. It's the most popular. It's the gold standard. In some cases, it's the gold standard because the Americans said that it's the gold standard. But 50% of the cases at 20 years needs to add medication or needs to have a second surgery. That is in the Otago glaucoma surgery study, which was a large, with something like 900 trabeculectomies done and followed for 20 years. The surgery that we prefer, at least in Europe, and here the KKESH has a lot of experience, even in children, that is fantastic, is the DS. And the DS, one of the guys that has more of these results is André Mermont in Switzerland, and he already have a 10 years of follow-up in which the qualified success was in 80%. It means control of the pressure with medication, and in 50% of them without medication. So it's quite similar to the trabeculectomy results. The key steps is, in some cases, peeling that out in wall of the Schlemm canal. But the important thing is to have a slowly decompression of the eye. So that's why the anterior chamber looks so good the next day if there is no leaking, right? And what about the tubes? We have a lot of experience with the tubes. The reason why the tube and trap study said that we should use tubes before traps was based on the complications rate. But if you think about it, you say, well, the volume that those tubes and valves has and the space that I'm using in the eye, it really should be before doing a trap. It's something that to think about it. I don't have the answer for this. I think that I will look for that answer while I'm here. The rate of complications related to infections, it's quite low in DS, then seems to be less also in tubes as long as the tube is covered. If there is an extrusion of the tube, then the rate of endophthalmitis increases, of course, and the trap is the one that has more risk of late endophthalmitis. Based on that, where I will put those surgeries? Well, I will put my filtration at the midway. If the patient is phakic and I'm only going to do a filtration surgery, I will put it a little bit below. I will prefer to do a DS instead of a trap if I'm not going to remove the cataract. And for my opinion, the tubes and valves will be a little bit over the filtration surgeries. What about the rest of all the lasers we have? Well, right now, one of the best, in my opinion, is the ECP, because you can release the energy in the area you want to treat under direct visualization. That's the difference with the CPC. And it seems that in refractory glaucomas, it seems to work as good as the Ahmed valve, at least at 2 years follow-up. So it's a good option if you have a clear view, you can get into the area that you're going to treat, and you are able to do it. And you have the equipment, of course. There are some other new devices. We just have this one for demo here, so I cannot really tell how it works. But it seems that at 6 months, it gives also like 30% reduction of the pressure. The advantage that seems to have over the CPC, it's based on the release of energy. It seems to be less energy than the CPC itself. This is the one we have now. Here, the cycloplastia that is done with the ultrasound. The technology of the ultrasound, I was not going to do that. The technology of the ultrasonic is based on old technology. It has something like 25 years. It was used to treat brain tumors. If you see the difference, these are the marks that the CPC does through the sclera, and these are the modification of the ciliary body that is done, the cycloplasty that is done with the ultrasound, the UCP. But it seems that it's not only an action of the ciliary body. It seems that it's also modification of the suprachoroidal space and intrascleral space involved in the reduction of the pressure. How good it is? Well, till now it seems that reduce the pressure about 30%, and that seems to be our magic number. The only thing is that we don't have long data experience. There are some published 3 years that say that it keeps that low profile of pressure, and that it could be some early failure in 90 days, some late failures, or success more than 6 months. We will probably develop our own experience, and then we can talk about this and show to the world if it's really good or not that good. But based on that, and put in the place, I will put the ECP a little bit over the tube if it's only the ECP, the micropoles, and I'm not very fan of the CPC. And then if I have to do a phaco, then I will think about combining with the ECP. That will be a little bit my steps, but I think that each one of us should have their own steps. Of course, the DS and the UCP could be a little bit there, and then we have all these areas. What are we going to put in here? Well, we have the famous mix. What about the mix? Well, are all the same? They are not the same. This one, this year was without withdraw from the market due to a 5-year follow-up. It shows a loss of endothelial cells rate of about 30% at 5 years. But the worst was that it was constantly since the first year until the year 5 that loss of 30% endothelial cell was constant, especially if 2 of these rings are shown. This is a suprachoroidal device. This device has to be put in the suprachoroidal space, and you have to only leave 1 ring out. But sometimes due to the technique, which is not easy, you can leave 2 or 3. The longer that part of the tube is outside, more risk of endothelial cells lost. And this other that is also was a suprachoroidal device, it's called the Supra from the Glaucoma. They designed not to launch that device, waiting for the result of the CPAS study. As the CPAS study came that bad, they decided to not launch that device. So right now we have all of this mix for trabecular use, the Glaucoma 1 and 2, the trabectom, the Hydrus, and the dual blade. Hydrus is going to come out, not yet. In Europe, we have been doing it a lot, but it's not commercially available. Suprachoroidal, there is no anymore. And the subconjunctival is the Shen. As you can see, here is the implantation of the supra, and this is the way we put it in the suprachoroidal space. It is a lot shorter, but we don't know what will happen with endothelial cells. So about the eye stent that are very popular and in some cases expensive, we have a long experience right now. It's going to come, I think, 12 years of experience. Dr. Neuham that published this paper at 3 years of follow-up and is coming to the Saudi ophthalmological meeting in March, had published recently 5 years of follow-up. And basically he used it in patients with laser treatment, with traps, and with the same results. Result of reduction of about 30% of the IOP and a decrease in treatments of about 80%. We used to have this machine here, the trabectom. What it does is it do a trabeculotomy, internal trabeculotomy with an electric shock. It's like an electrode. But the results, that is also about 30% reduction, it seems that stopped working around 2 years. So that's why it's decreasing the popularity. The Kahoot dual blade is similar to the trabectom. Also, that magic number of the 29 decrease at 1 year, I think is cheaper than the trabectom, but I don't know the advantage. We use it for a year, and a year control the pressure well, but after a year start rising the pressure again. And this is the Shen. What is the advantage of the Shen? The Shen is a device in which you really do like a trabeculectomy, but from the internal part. You can see the tube here through the conch, and here all the tract in the subconjunctival space. What it really is a trap with a tube that is based on the length of that tube and the diameter of that tube. But it's not really a mix, because the care of that bleb has to be the same as a trabeculectomy, except by the suturolysis. You have to use mitomycin C, and right now the first step of the surgery is leaving a mitomycin under the conch that you're not going to wash. So what is going to happen with that mitomycin under the conch without washing it? It will be a problem we will see in the future. But well, I think that mix will be around here, especially if you're going to combine with the phaco. You can do all of the mix you want, depend on how well you feel. In my opinion, the shunt could be a little bit one step ahead. And the advantage that I see is that you use the nasal area, which is difficult to reach for another trabeculectomy. So consideration for trabecular surgery will depend on the state of the glaucoma. Should not be a very advanced glaucoma, should have pressures target around 16, the angle should be open, and should not be synechia. And it's better if you're going to combine with cataract surgery. So our patient, the one that I showed you before, in this condition, probably is a patient that you can consider to adjust a filtration surgery in the worst eye and any mix in the better eye, especially if the patient is going to go under cataract surgery. To summarize in 3 slides, Glaucoma Solutions will depend on where is the damage. We have different tools right now, so we can adjust those tools according to the damage we found. And at the end, we can put into the poor eye, the first step, that one. The second will be a DS or a trap over the same place. Then you have space for the shunt or to put an Hackmet valve. And if that doesn't work, you have the Addy valve. At the end, these are the important things. Different types of glaucoma will need different clinical perspective, will need to analyze the pathophysiology to add the right treatment. According to the stage of the type of the glaucoma, you can add your medication or be aggressive or not that aggressive. And let the patient and the family be aware of the disease, because they are going to be your allies. The earlier the diagnosis, more things you're going to be able to do. The later, you will have to be more aggressive. And thank you again for your time and for your patience and for helping me to be at home. Thank you.
No, you are there. Thank you for such an excellent lecture. So now we're open for questions and comments. Siéntate allá.
Five minutes, you need to put drops. This means he needs to spend 30 minutes of his life just waiting for the drop to put it. So I think maybe surgical option is better choice in this case if you have like child who's using more than 2 drops to control the IOP. Because you know by time they will just miss up the medication and you will lose the control of the disease.
Yeah, it's an excellent question and excellent dilemma. Now, can you hear me at the back? Thank you. Dr. Vargas kicked me out of the microphone there. He knows that I'm going to talk a lot if I'm stay here. Anyways, that is a huge dilemma, you know, because you know that in most of the treatment of the patients, beside, for example, the example you gave, being in a kid, it depends on the family. So family has to be there. Family have to add the medication. Fixed combinations could be a solution. In some countries, the fixed combination, there are already 3 meds in 1 bottle. That simplifies the administration, but it's not available everywhere. What it will be the solution? Well, you know, in Europe, we have one idea. When we talk about congenital glaucoma, we always think it's surgical solution. Since I've been here, I have to look for other options because the surgery is going to help, but as I show, in most long-term surgeries will fail, all of them. I don't know if in the room there is someone that can warranty that the surgeries is going to last more than 20 years. In my hands, absolutely no. The surgeries will fail, as the study said, between 10, 20 years, if you're lucky. And it means that you have to do another surgery. No, I think that it means that you have to help that surgery sometimes with the art of medication. The problem with the kids, and it's true, the problem with the kids is that it's for the life. I did one surgery that my resident gave me just the movie and I couldn't add, that I did that surgery for 2.5 hours. It was a replace of an Ahmed valve that it was not working, and I put in the same place, based on a paper that I read in adults, was the first time that I did in kids, I put an ADI valve, a Farvel valve. Why I was concerned that that baby had already 2 filtration surgeries and 1 valve, and it was 3 years old. And I said, if I'm able to use the same space for a new valve that might work for 5 more years, I'm preserving the rest of the area for the ophthalmic pediatric department.
What about the use of mix in pediatric? Anything?
The use of?
The neo stents and...
You mean the mixed devices?
Yes.
In Europe, we don't have experience. The last thing I heard is not approved to be used in children, so I don't think we're going to use. Which one might work? That's my idea. Of all the ones I have tested, probably the one that has a space, it will be the Shen. Because Shen is like a trap. The only thing is that you will have to do needlings in the same way. And the only thing that I will probably think about is the use of mitomycin C as Allergan recommend. Allergan recommend 0.3 injected at the subconch, far away, but in the same place where you're going to put when the Shen is going to exit. You know, I have seen the effects of the mitomycin C with all these very thin blebs in long time, and you worry about what's going to happen if I leave it there and I'm not washing that mitomycin C.
Thank you.
Thank you.
Any other question? All right.
Yeah, there is also one thing add. We don't have in Europe as many cases of this specific type of hemoglobin that reacts to the acetazolamide. And here in this area, I think there are some cases of that you have to take into consideration. Well, back to the question. The problem with when you use the same family is that sometimes you don't get the right effect that you're looking, in this case, the decrease of the pressure, but you can multiply the side effects. It seems that by using it topical and orally, there is a difference in the side effects. You will have some of the systemic side effects related to the medication the patient is taking orally, but it will also add some effect in the reduction of the pressure. I can tell you the number. Honestly, I can tell you the number. But when you see in the reality, when you see the patients that we are treating, adults, kids, I don't know, but when you see the adults, you can see that even if they have full medication, and you add the diamonds, the impression is that the reduction of the pressure is about maybe 15–20%. It's an impression. I cannot tell you, I haven't read any paper in which you can quantify that effect, but it's an important concern because usually you use that type of treatment in advanced cases or in very high pressure in which you are looking for a sustained effect. I can tell you that in what I try to do, if I have a patient in full treatment, topical plus orally, I usually had it for a period, but I'm thinking in surgery, and it's my way to convince the patient that it will need sooner, better than later, a surgery.
So if I move the oral and topical carbon antibodies, is that better effect if I use three different pharmacological classes?
No, the best will be to use different topical classes. That will be the best. But when that fails and your only resource is to use orally the acetazolamide, it will be for a period. But if you can, what the rules always said is try to use different families. The effect, it will be much better. Thank you.
Thank you. Just
Yep.
yeah, just thank you for the overall overview of the lecture. Very nice. Just you mentioned there is a company who produces a 3 medication in 1 bottle.
I think it was in Belgium. I'm not sure. We don't have it in Europe, but in Belgium, a patient that I used to treat, it has pilocarpine, timolol, and dorzolamide, I think. The 3 of them came together in 1 bottle.
Do you know what is the consideration that the pharmaceutical do when they combine these different classes? Or just you can compound it here, for example, if you...
For many years, it was a problem. We were always asking why the brimonidine could not come together with the brinzolamide, for example. And the excuse that Alcon was given was that it was difficult to prepare a suspension with a solution mixed together with the right biodisponibility. But I'm not very clear on what is the problem. But Simbrinza came out many years after that, you know. So it seems that it's something related to the way the medications can be mixed together. Some of them will precipitate in the same bottle. So that's the problem they usually face. Another thing is the economical benefits that they are going to get. That probably it's the most important. What we faced in the last 2 years in Europe was that some of the all good medication that we used to have disappeared from the market. And the reason was that it was not cost effective for the pharmacological enterprises. That's what they said.
What about the Japanese group who produces the ROCK kinase inhibitors as anti-glaucoma? What is the role of that?
You mean the Santen group?
Yes.
Santen group that has the tafluprost and the...
Not the Santen group. There's a ROCK kinase inhibitor.
Okay. You are talking about the new ones.
Yeah.
Okay. Well, those ones are going to come out now. The ROCK kinase inhibitors, and those ones seems to work because they are totally different families now. So if we talk about the future, they are going to, probably in the next 5 years, it's going to be launch probably 4 to 5 new medications. And 2 of them are from a different family group. So we're going to have now 6 options in the future. And some of them are the ROCK kinase that could be joined to the prostaglandins analogs like the latanoprost. There is already a fixed combination working on that, and it seems to work very good. We will have to wait the results. You know, sometimes there are a lot of promise and say, oh, this goes very good. What it was good is that until 1999, 2000, we only had dorzolamide, timolol, pilocarpine, and adrenaline. Suddenly came the latanoprost. Latanoprost was for the glaucoma specialists was like, you know, the heat, because it was the medication that the dose was only once a day, the power was outreach the beta blockers, and patient has a very good tolerability with very little general side effect. They were only local. So I hope it's going to be the same thing with the new medication.
That's a good question.
No, that is not a good question. That is a very difficult question. You know, we always said that there is about 10 to 15% of our patients that no matter what we do, no matter what how we control the pressure, they are going to progress. Sometimes, you know, for me, it's the same thing, and I have one case that came to my mind when you asked me about this. It's a normal tension glaucoma patient. And even having 10, 12 of pressure, she was progressing. And she was not feeling the constriction of the visual field. So when I offered to her to do a surgery, she was like, what? Are you telling me that the best option to stop the progression is to do a surgery? 20/20 vision. And I say, well, you know, even all the drops you are using, you're still progressing. And what I'm seeing is that you're going to probably end it blind. So at the end, I did a surgery and slowed down the progression. I followed her for about 6 years. Then I moved to another hospital. I don't know what happens to her. I hope she's still fine. But one point when you do a research is that there is a difference between meds and surgery. One of the difference is it seems that the surgery stabilizes the pressure, avoid the fluctuation of the pressure, and it might slow down the progression if you are lucky and the patient is lucky too. So probably if I'm aware that the patient is having a progression, I probably will look for a surgical option. Don't know what, but I will probably look for something more aggressive if I really can show that there is a progression in that patient. Yeah, I had the feeling you were going to ask me something like that. And I do not have a real answer for that. We had a lot of discussions about the use of alternative therapy, you know, hyperbaric oxygens or ginkgo biloba or some antioxidants or medication that produce a vasodilation. Sometimes I give, but it's the feeling like I'm going to give something that I don't really know if it's going to be better for the patient or better for my conscience. But I believe in neuroprotection and that some of the factors that produce vasodilation and improve the ocular blood flow might help this kind of patient, absolutely. But there is very, very few literature about it.
Okay, I have one comment and one question. Where do you think that the technology is leading us? When I did my residency, 1991, I started doing extra cap. So we have to open like 12 millimeters. And from extra cap, we went to phaco. And we still have to open like 6 millimeters incision because we didn't have foldable lens. And then we went to 4 millimeters, 3.5, 2.2, and mix that we do 1.8 millimeters. So the technology have led to something less invasive than many years ago. So where do you think that the technology is leading us? Trap? Or what is going to occupy those steps? Traps? Or maybe those new devices to be implanted in the angle? Or laser technology? Or maybe new drops with new pharmacology? And the other thing that I want to make a comment is that education of the patient is very important. I have faced many patients that come to my practice here and for cornea problems. And when they're leaving, say, please, could you refill my glaucoma drops? So I say, okay, not a problem. And then I look at the track care. And then I see that the patient was seen 1 month ago, and the medication was prescribed for 3 months. My first question to that patient is, either you're selling the drops or you share the drops with some member of your family. Because we gave you 3 months of treatment. And this is 1 month after that, and you already don't have any drops. So the ones that I saw that video, I believe that if we educate the patients in the right way, and if they apply the drops in the right way, we might obtain a better control of the intraocular pressure and better results.
Absolutely agree. I think that as I said, you know, the best treatment used in glaucoma is the treatment that is used right. There is no, when we right on indicate, you know, like a lot of medication because the pressure is in 40. And the patient show up with 40 of pressure, primary open-angle glaucoma. You find it at the ER. And you say, I'm going to give full medication plus Diamox. You know, I think if in a lot of those patients, if you give one drop, you try to reduce the pressure at the moment. But if you give one drop and you explain properly how to use it and the people is involved around, probably the effect is going to be as good as the full medication. Why? As I explained, you know, the more complicated the regime of drops is, the less the patient are going to compliance on it. So we have to try to really make the patients understand. In some cases, it's like, here it's very common, at least I found that the patients, it happens also in Spain, they come and they said, you know, I ran out of the medication. Yeah, but well, you should not wait until you see the doctor. You go, you buy it, you get it, because this is important to keep the pressure stable. High fluctuation of the pressure causes as much damage as high pressure itself. There is one difference. If you keep the pressure in 30, your optic nerve, your blood vessels are going to get used to that pressure. But if your pressure is 18 and suddenly you drop the medication and the pressure rises to 30, the blood vessels get used to the 15, not the 30. And that's where the problems comes of vessels occlusions and things like that. Where the technology is leading us, I think that there is a lot of money involved in this. There is a lot of research. There is a lot of research in surgical devices. The InFocus will comes out. The InFocus is like the Shen, but it's applied from the outside to the inside. I think that all the glaucoma surgeons likes to reduce the size of our surgeries. A lot of medication are going to come out, as I explained. I think that there is a huge revolution in the following years. We're going to hear a lot of news. What is the risk in this? The risk in this is that sometimes we get too much hurry on trying to put in our practice some of the devices, and then 5 years later came the CPAS case. You know, the side effect of some of these devices, we don't know. They are going to come. And then what are we going to do with those patients in which we promises to control the glaucoma with this device, and the device is causing this other problem? You know, it's a complicated situation in that way. But there's going to be a lot of things. For the ones that are going to thinking about joining the glaucoma, that will be the field. You know, you're going to be excited with all the surgeries, with all the medication, and with all the pathology we're going to have.
I strongly believe that there is a lot of coming on for new technology for treatment. But there is also something good. They are in the phase 2 right now in the United States for a device that is placed through the pars plana with a neuroprotective factor, a neurogrowth factor. And this is going to be very good for the patients who already have a very severe optic nerve damage that, according to these phase 2 trials, most of these patients improve in the visual fields and improve the results on the optic nerve OCT. I think that this is going to be something that, besides the treatment, this is something that we have to keep an eye on it.
Yep, absolutely agree. Yep.
Yeah. Any other question? Well, I think that thank you for coming, and thank you for Dr. Conrad for being here.
My pleasure. Thank you.
right?
I have no idea.
So I don't have a hand. Can you plug off? No, I mean, just in case I don't want the answers are there.
Sure. Yes, I can.
You're the best.
Interview.
Sí, no, para que ¿qué pasó, coño? Además, sacaste las patas del barro, ¿no? Los sangre no me son. Sí. ¿Qué para eso? Thank you. But I don't have paper. I don't know, they use paper. Yeah. So I don't have it. Hi guys, how are you? So today is my responsibility to give to you the weekly quiz. There are going to be 5 questions, no, as usual. I'm going to give it to you 2 more as an extra bonus. Okay? The two last questions are for extra bonus. If you answer both good, correct, this is going to be valid for one of the first 5. You have to answer 2, no, the 6 and the 7, correct, and this is going to be valid as one of the first 5. Okay? Probably you're not going to need it. Probably you're going to solve it with the first 5. Okay? Let's start. Can you read from there? Features that serve to distinguish congenital hereditary endothelial dystrophy from congenital glaucoma include 1. Intraocular pressure, 2. Epithelial edema, 3. Corneal diameter, 4. Corneal thickness. And these are the answers. You have 1 minute to answer. Looks like a conversation, no? $50. Which of the following statements about homocystinuria is or are true? 1. This disorder is an inherited of an autosomal dominant basis. Most patients will develop ectopia lentis. 3. Systemic mortality is caused by coagulopathy or with clothing deficiency and bleeding diathesis. 4. The primary defect leading to lens dislocation is a structural deficiency in the sonulus. These are the answers. You have 1 minute. $50. Which one of the following statements about Coats disease is false? A. True Coats disease is a disorder of the childhood, more often affecting boys. B. The condition is more commonly bilateral than unilateral. C. Diagnosis of Coats disease may not be made in the setting of subretinal exudate without obvious abnormal retinal vessels. D. Full treatment involves obliteration of the abnormal vessels and subsequent treatment of associated retinal detachment. E. In up of 1/2 of untreated cases, the condition may be non-progressive. Just wait for it. $50. True or false? Retinoblastoma that grows into the vitreous humor in a mushroom or in spherical shape is termed exophytic. 50 seconds. The next two questions are the bonus questions, okay? Two questions. This is the four? Okay, let's go with it. 5. True or false? If the inferior oblique muscle passes between the inferior rectus muscle and the glove on the way to its insertion. Just one more question, okay? It's going to be a gift for you. Just wait. To accurately quantify an SO deviation, a prism is most appropriately placed over either eye, A, base up, B, base out, C, base down, D, base in, E, apex out. This is a gift. Done? First one? This one? No, the last one was a gift. I mean, super easy. 6 to answer 5. Okay? 6 is in case that you fail this one. Done? Done. Huh? There are, and the next. Okay, again. This one? Ready? The one again? The second one. Okay. Thank you. How are you? Done? Okay, let's start with the answers. Done? Okay. Any brave who wants to give us the answer for this one? Nobody? Huh? 1 and 3. Anybody has another opinion? One? Okay. So your answer is? A. No more bets? Okay. The answer is B. You were right. Congenital hereditary dechet occurs secondary to a defect of the corneal endothelium and descemet membrane. Although the corneal edema may resemble that seen in congenital glaucoma, there is no elevated intraocular pressure or increased corneal diameter. Okay? B. Bravo. What about here, Adolf? See? Other option? See? Good. Homocystinuria is an elastosis and leads to hypercoagulability with thrombotic vascular occlusions. The elastosis also causes defective sonular function and ectopia lentis in 90% of patients. It's inherited on an autosomal recessive basis. Very good. 4. Which one? Do you want to skip? I mean, So we can, if you want, we can. Okay. No, you. Do you want the answer? Ah, but you don't know the answer and you want the answer. Okay, the answer is D. Okay? D as delta. Okay? Persistent hyperplastic fetal vascular persistence occurs frequently in small eyes, whereas retinoblastoma rarely occurs in association with microphthalmia. Okay? Clear? The last one was a gift, so I hope that everybody. Here, Coats disease. B? Any other option? 90%. And why not 95%? Okay, the answer is B. Coats disease is more commonly unilateral than bilateral. Abnormal vessels must be present either by direct examination on fluorescein angiography to make the diagnosis of Coats disease. Okay? B. But today I saw a patient with bilateral Coats, no? This one. False. How is called this when the retinoblastoma grows to endophytic? Correct. Okay. Everybody clear with this? Wait. That's one. This one. True or false? Sure? Sure? This is a gift. False. And this one. Another option? No? Correct, B. That's it, no? Thank you. Nobody answered. Ah, you didn't see it? So, that's why.
All the answers below it will be belonging to the after question.
Yeah, no, it's okay, No, the last one, I take the last one as a,
If you can see here, nobody answered slide 7.
No, because
you only saw 60 slides.
no, because I was watching here, so I don't know what happened. I mean, there was a difference.
We did not see it at all.
No, it's okay, but
So here, nobody answered 7, only 6.
Okay, it's okay.
I mean, below it, it was the 10th question. So we are answering the question as it is the fourth.
You?
All of us.
Yeah, you answered the third as a fourth. Yeah. Okay. As the fourth. Okay. Don't worry. Thank you, Professor.
This is yours, doctor?
Battery.
دقيقة خلي أحطه أسلم عليك مضبوط. شو أخبارك؟ شو مسوي؟ شو مسوي؟ والله الحمد لله بخير. أنا معك ترى. تبغى وصلة؟ أجيب وصلة؟
موجود.
ولا اتش دي ماي؟
اتش دي ماي موجود.
أشبك على اتش دي ماي. طيب أقدر أشيل اللابتوب هذا؟ طيب وش تبغاني أسوي؟
خلاص شو صار الجهاز؟ اشتغل الجهاز.
يعني ما في مشكلة؟
اي مش مشكلة. سنة صح.
والله صحيح. تبغاني أصير عشان أسجل؟
السيستم حقنا ما هو قاعد يسجل
اللي تشوف. لا ما نقص شيء. هذا المايك. خلاص. تمام تمام بس ابغى يطلع لي بريزنتر فيو هذه. ما تطلع. مدري والله. لا ما ينفع كذا. ايه تعرف تسويها؟ بعدين
ايوه بعدين
ماستر جوبز.
وحدة دوائر دكتور. خلينا نشوف دورة واحدة هنا.
ايه ميرور.
الميرور بيخلي نفس الأرض هنا. وش الميرور؟
طيب ميرور اوف.
كذا خلاص ما ابدا.
طيب
الميرور هو نفسه.
طيب كذا. ايه لا. أحمد متى تبغى نبدأ؟ نبدأ. طيب السلام عليكم جميعا. حياكم الله. خاصة الأرون اللي توهم بادين. طيب أتوقع أحمد قلت لهم عن الموضوع وشو. بنتكلم عن الآيول calculation. So nowadays, as you know, يعني the patients are highly demanding. They are asking for 20/20. They are asking to get rid of presbyopia. So just to do cataract and put any IOL power, يعني you will be in a big problem, and the patient will ask for IOL exchange for sure. So what is your aim when you are selecting IOL for a patient? Usually, what is your aim? Mm-hmm. Okay. best visual acuity, how can you reach best visual acuity? And let's say this is the patient, okay? Which IOL you will choose for him? Which type, which power? Yeah, how can you make the patient satisfied? Okay, what you will ask him in history? Why the age? يعني if the patient above 50, you will give him monofocal? Would you like to give the patient the option for multifocal or a trifocal versus monofocal or no? Or you will decide? How can you explain to the patient that you will go for trifocal or monofocal? Yani what are the advantages of monofocal over trifocal for the patient? All the patients interested in both.